I would now invite Professor Bibhuti Prassan Sinha, Professor and Head of IGIMS Patna. He was the organizing secretary of the first midterm conference of AIOS and has been the chairman scientific committee and the secretary of Bihar Ophthalmological Society. Dr. Bibhuti, your talk.
He is actually heading the biggest RIO of India, who is going to come up in few months from now. So Dr. Bibhuti, who is going to take up another important cases of phacoemulsification in the case of operated trabeculectomy, which is again a challenging for the cataract surgeons.
Thank you, sir, Subhas sir, for giving me this opportunity. I'll be talking on the phacoemulsification.
Excuse me, can you set the timer? It's 7.3, 7:30 seconds.
Match fixing was done a little earlier.
Please do it 10 minutes.
8 and now it is 7:23.
Please do it 10 minutes. Yeah.
Anyway, so phacoemulsification in the case of operated trabeculectomy. I'll try to save 2 minutes at least. So, yeah, please slide change. It's not happening.
Slide is not here.
So it's a challenging proposition for any surgeon. Glaucoma requires lifelong management and development of cataract. It is a significant concern because it leads to loss of IOP control. And as with cataract formation, the visual field estimation becomes very difficult in the patient of glaucoma. That's why it's also important. And also, the most of the bleb failure occurs soon after the cataract surgery. So it's a double-edged sword. So 3 scenarios you can get. One, the first one, where you can have a fully vascularized kind of bleb which is dysfunctional. So there the operation is more simpler because you are not worried about the survival of the bleb. In the second case, the bleb is somewhat working, and there you have to work to safeguard the bleb. And the third one is a very overhanging kind of the bleb where the chances of rupture during the surgery itself exist. So these are the different scenarios where you have to deal with. So coming to the introduction, trabeculectomy increases the risk of cataract formation, and the major factor for the risk formations during the trabeculectomy are complicated post-operative course, flat anterior chamber, and post-operative inflammation. According to ages, it is about 14% increased risk of cataract formation is there with the trab. These are confounding factors which are present when you operate upon a case which has been operated for trabeculectomy. So low endothelial count, poor pupillary dilatation, atrophy, shallow anterior chamber. Everything is there. The post-operative uveitis can occur, bleb failure can occur, and post-operative enhanced need for anti-glaucoma medications can occur. Loss of IOP control also occurs, and several factors are associated with the loss of these issues. Eyes with higher IOP before phacoemulsification, there are more chances that the patient may land up with a failure of the bleb. Younger patient, there are more chances intraoperative iris manipulation. There are more chances that will lead to little increased inflammation in the post-operative phase. Early IOP spike, posterior capsular rupture, or the interval between the trabeculectomy and cataract surgery is less than 6 months. So if your bleb is not mature, there are more chances that the bleb may fail. So allow at least 6 months after the trab, or allow the bleb to mature to get stabilized before you do the cataract surgery. So what is important in the pre-operative evaluation? Evaluate the bleb function completely, and also make a note of it in the pre-operative diagrams. IOP measurement, gonioscopy to see the ostium, extent of the optic nerve damage, and the corneal endothelial count. Topography can be done. Assessment of the pupillary dilatation is very important because these pupil are not going to dilate fully, and they'll give you much bigger challenges during the cataract surgery. Evaluation of the type of the cataract and the lens density, and rule out the jonular weakness and the pseudoexfoliation also. So coming to the important thing is use this kind of speculum, not the speculum with a toothed edges, because they can damage this kind of the bleb which are present. Usually we do topical anesthesia, but subtenuous injections can be given into some other quadrant. Retrobulbar don't try to give, and the super pinky should not be applied upon. Clear corneal incision should be used much away from this site. This is the bleb extent, so you can use a site little away from the bleb ending edges To counter the pupillary meiosis, high viscosity viscoelastic agents should be used, and dye during the capsulorhexis should be used. Apart from that, most of the surgery is like a regular surgery. Only thing is it has to be a slow one under a low infusion. So low infusion, low pressure has to be created, intraocular pressure. With the newer machines like Centurion, you can have better IOP control in intraoperative IOP control, and that will safeguard your bleb also. So hydrodissection, nothing more, but one should do what you are basically master of. If you are good at stop and chop technique or a 4-quadrant or even the direct chop technique, use it, but be in the bag during the phacoemulsification technique. And during the IOL insertion, also try to be little slow and steady into the anterior chamber, because there are more chances that the haptic may stuck up during with iris or even during the into the angle, and that can cause lot of problem to the patient, and that will lead to inflammation and finally to the failure of the blebs. So at the end of the surgery, what you have to do is a thorough viscoelastic removal is mandatory. If you leave the patient with lot of viscoelastic into the anterior chamber, that is going to give you a bigger spike in the post-operative phase, and that is ultimately going to lead to failure of the bleb. Bleb function must be assessed like this one. This bleb which was having a very large ostium, and this gave away during the subtenon injection only, and the patient has to be taken up for a repair of this whole area by putting a tenons graft. So one has to do a proper evaluation of the bleb function by injection of the BSS and do a Siddle's test at the end of the surgery to find out if there is a leakage or not. If there is any kind of leakage, it has to be dealt immediately, or else if the bleb is not well functioning, then you can think of doing a little revision, bleb needling and injection of the 5-FU during the surgery itself. So post-operative consideration, close monitoring has to be done. Monitor the IOP spike, watch out early signs of the bleb failure, and there you have to intervene. Vigorous steroid to minimize the post-operative inflammation is mandatory. Early detection of the cork screw vessels, appearance of the cork screw vessels is a sign of the bleb failure, and that has to be dealt aggressively. Subconjunctival FU in cases where you are dealing with a kind of the bleb failure or the patient which has already a vascularized bleb. So these are some of the studies where you can find out that in the post-operative phase, there is loss of IOP control from 10 to 12.1, 14 to 15.3, 8.72. So approximately 3 to 3.5 millimeter Hg of IOP increase occur, millimeter of Hg of IOP increases in the post-operative period. So to end with my talk, the pearls are delay the cataract surgery until the bleb has matured at least 6 months, or assess the bleb function before the surgery properly, evaluate the pupillary dilatation before doing the surgery, and then also the endothelium, minimize the subconjunctival trauma, also minimize the iris manipulation during the surgery. Small cornea incision as far as away from the bleb has to be done. Assess the bleb function at the end of the surgery and aggressively treat the intraoperative or post-operative inflammation. These are some of my references. Thank you very much, sir. I've been able to safeguard 2 minutes again, sir. Thank you.
Thank you, Dr. Bibhuti, for presenting in such an excellent manner